Well, good morning, everyone. And I hope you can all hear me now. My name is Eileen Halberd, and well, there we go. I'm the executive director here at 2Life. And so if you can hear me today, then you have successfully joined today's program that will focus on cognitive health and breast cancer treatment. And so today's program is part of the Women's Health Conference series. Today's program is the fifth in a series of 6 programs. We have one more coming up in January, later January. Melanie, I'll tell you about that. And so I'd like to just say just a couple things, and then we're going to get going with the program. We have a lot to talk about. We should be together for about an hour today. Dr. Bremser will speak for the first half an hour or so, and then we will take questions. So I would like to invite you to put questions in the Q&A or in the chat box. We will monitor those questions. You can put them in at any time. And then once Dr. Bremser completes her remarks, I will ask her the questions through the forum so that everyone hears the question and we can talk further about the conversation. So, in any event, today's program is sponsored in part by a few people, and I'd like to thank the New York State Department of Health, Mona Corporation, Genentech, and Saratoga Hospital for being part of the underwriting for this particular series, and we're real happy to have your support and happy to have everyone joining. We've got a big crowd with us today. A couple other things I will mention to you. You have all been entered in no video and in mute mode, and so you'll use your question or chat feature to engage with us, and we'll get questions answered. And so with that, I would like to get started and do an introduction for Dr. Bremser, and I know she is waiting, and she will share her screen in just a moment. So Jennifer Bremser is an associate professor of psychology and neuroscience at SUNY Plattsburg in Queensbury. She holds a PhD in psychology, behavioral neuroscience, and has specific training and research experience in neuropsychology, which examines executive functioning and other cognitive tasks via brain performance testing. In 2014, Dr. Bremser was diagnosed with HER2-positive breast cancer. She did participate in a clinical trial with radiation endocrine therapy, and so has direct knowledge of the cognitive consequences of treatment and their persistence. Her research on estrogen-dependent aspects of cognition has been published in a number of peer-reviewed journals. And with that, I'd like to invite Dr. Bremser to speak, and we're so delighted to have you and to talk about a topic that I think is important to all of us. Thank you.
Thank you so much for having me. Is it, you can all hear me, or give me a thumbs up if you can hear me? Okay, I'm used to teaching across the Zoom format, so I don't know, I might use some of those tricks, but I miss seeing people's faces. So I will start by telling you that I will miss seeing your faces because I use a lot of facial cues to guide how I speak. So without that information, I feel like somewhat I'm talking to a void, but I will be doing the best that I can to talk to you today. And of course, if there are any questions or something that I say is confusing, please don't hesitate to put it in the chat and we'll have a chance to talk about it later. One of the things I've already put in the chat is a link to my presentation in case anybody wants to access it later or forgets my contact information that I included at the end. You can have that handy, and of course I can share that with anybody here today that would like a different copy of that or to put on the website. I'm going to go ahead and start to share my screen with you today. And I have my presentation right here. So let me just get into the presentation. And looks like I have to go to the beginning here. So today I'm joining you, and I thank you very much for the opportunity to talk about the effects of breast cancer treatment on cognitive health. And as you heard through the introduction, I have sort of lived on both sides of the street as a researcher who's interested in the effects of estrogen on cognition, and also as a person who's experienced the effects of breast cancer treatment and cognitive changes that go along with that. So I'm really happy to be here, and I appreciate the opportunity to speak. I thought about what I might start with, and I don't know if it's true for a number of you in the audience, but once I got through my treatment, which lasted about a year, well, and then I guess 5 years if you include tamoxifen after that, I had this idea that recovery was going to be a lot like this expectations, that I can get back into life, get back to engaging in work the way that I did. I have to do a lot of public speaking and organizing and planning and synthesizing material as part of my job as a researcher and also as a professor. But what I really discovered was that the picture looked more like reality, and it's a messy line. I remember I got a day planner in 2016, which I finished my chemotherapy in November of 2015, and the day planner said something like 2016 is a great year to have a great year, and that year turned out to be quite difficult. So so I don't know if you can appreciate that the experience that I had, but I thought that might be a starting point for today's talk, and to just talk about why the reality might look like this for many of us. And the first thing I wanted to do is validate any concerns that you have about the presence of cognitive changes that take place as a result of cancer and cancer treatments. And these effects are real. These effects are substantiated in a number of ways, using different models, using humans, using animals, using brain imaging techniques. So the first thing I want to do is make sure that you understand that there's really no question about the existence of these cognitive changes. The research is clear, and I took a little screenshot here of a paper that was published in 2011. One of the things I thought was interesting about this article is that it's not in an oncology journal, it's in a pain and symptom management journal, which might talk about or help us think about why there might be a lapse between what we know research-wise and what clinicians, medical oncologists, radiation oncologists might be able to do to help us with these problems. And as many as 75% of patients experienced cognitive changes at some point. So the people who experience these consequences are in the majority and not the minority. So what I'm going to talk about today is the cancer-related cognitive impairments. And these are really subtle but significant cognitive changes that follow both the diagnosis of cancer and cancer treatments. And I'll talk more specifically about these changes. But to begin with, these changes are known to impact things like memory, processing speed, and a set of cognitive functions we call executive functioning. And executive functioning is really what is important in what helps us plan and organize our behavior so that we can achieve our goals. And one way I like to think about executive functioning is I like to think about a hockey game and what hockey players sort of have to go through to achieve their goal, which might either be to score or block the opponent, or to score a goal or block the opponent from doing so. And in order to do this, you have to initiate a plan. You have to organize yourself and your materials to execute that plan. But as this plan unfolds, we have to update what's going on. So, for hockey players, at one moment, a puck might be going in one direction, but the next moment it might be going in a different direction. So that requires an update to the plan and what's called set shifting. In addition, there's multitasking that has to go on. So coordinating your hands on the stick, where your eyes are, where your body is in space. And at the same time, it involves some response inhibition. So, you might be skating in one direction, but suddenly you might have to turn and move in the other direction. And what you have to do in order to keep moving towards your goal is stop what you were doing, change, and move to the other side. So these executive functions are very important in any goal-directed action, and they involve things like attention. Other places where you might see some trouble with executive functioning could be things that are associated with attention deficit disorder, and also the effects of brain injury, particularly concussions or mild traumatic brain injury. And some of my prior research is on hockey players. That's why I think that that metaphor just sort of clicks for me, is because when we tested athletes a number of years ago, what we found is that hockey players were really good at set shifting, which was meaning making their plan and then changing and updating their plan. And I think that that kind of tells us that there's more than one way to achieve these success in these cognitive domains. It doesn't necessarily mean you have to do a lot of like game playing, like on those neuro app games that they might have you do, but through movement and moving your body is one way to get that as well. I also started to just point out some of the brain areas that we know are involved. And for example, for memory is, I said it's a midbrain process. And that means that like if we were to slice the brain in half and sort of open it up, you would see these other structures that aren't available from looking at the surface of the brain. And memory is within these midbrain structures. The frontal lobe functions are what is most associated with executive functioning. That also seems to be impacted. And then processing speed. Processing speed is how quickly we can accomplish our goals, but also process information. And so the temporal lobe is here. And I thought I would start with that. So when we look at how many people can be affected with these cognitive impairments, what's interesting is that up to 40%, let me start out by saying that there's a large amount of variability in the research for how many people are affected and when. But I've tried to find and sift through the research to at least give you what's more known or been observed more than once. And so before treatment begins, this would be after somebody's been diagnosed with cancer but has yet to receive any chemotherapy, about 40%, 33% of people will show some cognitive changes that occurred even before the onset of chemotherapy. So that makes us think that there's other things besides chemotherapy at work. And I'll talk about some of that as we go through the presentation. During treatment, about 75% of people will report some changes in their cognitive function. And then after treatment, again, the numbers vary widely, but between 25 to 35, 40% I saw, this trouble can persist. And even up to 60% of participants in some studies say that the cognitive effects are persistent after they ended treatment. And this span of time, again, there's a large range of variability, but it goes anything from 6 months post chemotherapy up to 22 years. And what this might suggest is that because there's a pre-treatment presentation and a lot of variability in its presentation, there's probably multiple causes and risk factors for these cancer-related cognitive impairments. Here is just a sample. I will not be talking about all of these, but a sample of the brain areas that have been shown via research to be impacted by chemotherapy. So specific to chemotherapy, you can see that the effects of chemotherapy are pretty widespread on the brain. And although this looks like it's just the surface, the outer cortical areas of the brain, what they're actually pointing to are some midbrain structures in here, but this picture isn't very good at detailing those. But this just is here to give you an example of how widespread some of these changes are. And again, I know there is a lot of information in this slide, but this is just to give you an idea of what types of cognitive functions researchers have looked at. And they're things like working memory. And our working memory is what we do to monitor and temporarily store or manipulate information. So this might be if you walked into the grocery store And you're like, I don't need a list. I know the things that I need. And you sort of rehearse what you're going to get as you get through the aisles. The Target is a terrible place to do working memory tasks. I think they must have some psychologists working in the background that have learned to disrupt this memory process, and they use it to their benefit, because I can't tell you how many times I might walk through there saying I need paper towels and ibuprofen, and I come out with a cart full of stuff except for paper towels and ibuprofen. Other things that are listed in here are our verbal memory. That might be our ability to retain linguistic information. So if you have to do something that requires note taking, it might be hard to kind of stay on track. So anyone who could be a student or in a job where they have to take notes. Processing speed is the time it takes to fluently perform relatively easy tasks or tasks that we've learned well. Things like attention, reaction time, and even motor speed. So precision and coordination within our body's ability to make movements. These are all things that have been investigated and all things that have been shown to be affected at one level or another through cancer-related cognitive impairments. This slide's overwhelming. This picture is taken from the same article that the previous slide was, and here they're just mapping all of those cognitive changes to different parts of the brain. And again, like I said, it's kind of hard to see, but what we're really looking at is, I made a little Pac-Man picture here. It's the frontal lobe and the temporal lobes that seem to be most affected. Some of the things like visual spatial memory might also engage other lobes of the brain. The occipital lobe is where our primary visual cortex is located, but it's primarily frontal and temporal lobe processes. So how do we know about these changes? How are we measuring these changes? What are our participants' characteristics? Things like that. So giving a talk to a group of breast cancer survivors or people who've experienced breast cancer, most of the research is done on people like us. And there's a couple reasons for that. The first one is that we are the largest population of survivors. So we are a rich pool of data that people can do research on. And the other benefit from breast cancer is that the treatment options often permit comparisons between different types of treatment. So some people may have lumpectomy and radiation, but they may not require hormone therapy or chemotherapy. So we can still sort of look at what are the effects of cancer compared to, and I guess radiotherapy and surgery, compared to when we add on additional treatment modalities. So what happens when we add on chemotherapy, and what happens when we add on hormone therapy. So it makes a nice design, sort of a naturally occurring experiment, because in all of this research with humans, we really can't randomly assign people to condition. We just, as a participant in a clinical trial myself, sometimes people will ask me, well, weren't you afraid that you weren't going to get any treatment at all? And I said, cancer trials don't work like that. They're always comparing the new drug to the standard of care. So in the same way, they're never not going to give anybody treatment, but these naturally occurring differences in how breast cancer is treated allow for researchers to explore what could be the unique effects of chemotherapy versus the unique effects of hormone therapy. And there's a variety of research designs that are used to look at this cognitive impairment. The first one might be self-reports, and those are questionnaires or surveys that are given to patients. And it might be a place where they can, in the literature, they're called cognitive complaints, but I don't really like the word complaints that much. So I would just say things that people who have, the concerns that people have with their cognitive performance. And self-reports do show that people who've experienced chemotherapy and other types of treatments for breast cancer do suffer from these cognitive concerns. The other source of data for this is performance on neuropsychological tests. And these are typically standardized batteries that have been created really to assess the status of brain injuries. So things like concussion, things like strokes, they've been used historically to look at recovery of function after somebody's received brain damage. They also are used to detect the presence of neuropsychological disorders. So for instance, some learning disabilities. My son, for example, example, just went through a battery of neuropsychological tests to look for dyslexia. And so these are batteries of tests that have normative data. So you can sort of compare how one person is to an age-matched control, and you can look at how their performance is different. And the other source of data can be brain imaging studies. These may be things like magnetic resonance imaging or positron emission. I can't remember the T. I want to say technology, but I might be wrong. But PET scans, MRI scans, they can look at the brain while you're performing cognitive tests. So people are actually in the scanner performing tests, and we get insight into what's happening in real time. And then animal research. So a lot of times we can do things to animals that we can't necessarily do in the context of human research. And we have behavioral tests that approximate some of the same functions or cognitive changes that we're interested in exploring. But we also need to be able to assess the quality of this research. And so I'm going to talk a little bit about research quality here. When we're talking about self-reports, I tend to think that they're accurate. People are mostly self-aware of what their baseline performance on cognitive skills may be. I think people are sort of their best, you're the best person to notice what's different about you. You live with yourself all day, every day, you're always with yourself. So I tend to think that these are a good indicator of what's happening. However, we may get used to some of these effects over time. And so, one of the things that humans do quite easily is habituate to their circumstances. And so we readily adapt to whatever we're put in. So, because these changes can be relatively subtle, we may not necessarily recognize in every case, how much change has taken place. The other problem with these tests is that doctors tend to think they lack objectivity. So because it's based on a self-report, we might be sort of they might be inclined to think that this is really due to problems with anxiety or depression or other things that could impact our cognitive ability. And as a result, doctors who tend to like data and objective data, even more than data, they might sort of like, I don't want to say in all cases, but some might diminish the truth to some of these tests. So to accommodate that or to correct for that, there was a trend to start looking at performance on neuropsychological tests. And these neuropsychological tests are part of the batteries that I described. On the next slide, I have a few examples of what these tests look like. However, what research has shown with these is that they may lack sensitivity. So for instance, when you take these tests, you're generally in a controlled environment without any distractions. And in real life, you don't have that working at work or at home. For the last 8 or 9 months, I don't know how long it is, I've been working from home while my kids are doing remote learning. And, the multitasking that goes on in that is not anything like me being in a quiet office with no distractions. So this may be one way that the neuropsychological tests aren't giving an accurate picture of people's performance. The tests may also not be the best because what they're examining is the outcome of our cognitive processes, but they're not examining the cognitive process itself. I'm going to come back to that in a little bit, but for now, I'll leave it at that. They're looking at the outcome of our cognitive process. And the next step is brain imaging studies. So interestingly, the brain imaging studies seem to correlate or corroborate patients' self-reports. So patients' self-reports seem to be backed up on what's found on brain imaging studies. But the problem with brain imaging studies is that they're expensive. They take a lot of time and accessibility. So, if you're outside of a hospital setting that's actively doing research, the idea that you could get a brain imaging study on the effects of cognitive impairment in a rural community, the chances of that are probably pretty slim. So there's some gaps in the research there. And then along with animal research, the comparison groups that we use, so between the tests that we have, they may mimic what humans have to do, but because there are inherent differences between mice brains and human brains, it's an imperfect match between what has to happen. And sometimes in these animal studies, the animals are just given the treatments, such as the chemotherapy regimens, but they're not actually given tumors. So in that case, we don't know how the effect of cancer would impact the performance. The other limitations that come up in research is the process itself. So for research, a lot of times what we have to look at is how long somebody's going to study a phenomenon. And that might mean, we have this endpoint of 5 years for survival, or we might have an endpoint of 2 years of looking at cognitive changes, because people want to keep their research rolling and they want to keep getting it published. So, for someone to examine the same group of people for 20 years is just not as realistic for a researcher to be able to say, well, we're going to use 3 years as our endpoint or 5 years as our endpoint. In addition, there's a decrease in funding opportunities, particularly for public funding opportunities. So if it's not based on finding a pharmacological intervention, there may be less money looking at things that aren't as profitable. And then again, there's pressure for researchers to publish. So that means in order to keep their job or get tenure, you're expected to churn out these publications. So given all of these limitations, what you could look for is something called convergent validity. And that's when the self-report data maps onto what we see in brain imaging studies. And it's also corroborated by animal research and maybe performance on neuropsych tests. So not using any one indicator, but looking for where the results converge is a good plan. I said I'd give you examples of some of these methodologies, and here they are. So for a neuropsychological test, this part A, part B is an example of one called the trail making test. And on part 1, it's kind of like a connect the dots, and reaction time is used as the measure that's being looked at. They'll look at errors as well, but not a lot of people make a lot of errors on this type of test. Part B, though, adds another dimension, which is set shifting. So it's being able to hold one set of information in your mind and then switching to another set. And as you can see, what a person would have to do in the second piece is switch between numbers and letters. So to solve this, you'd connect 1 to A, 2 to B, then B to 3, 3 to C, 4 to A. And so that's looking at cognitive set shifting. Another test that's used on neuropsych batteries is called the Stroop Test. And this is looking at automaticity, and response inhibition. So can you inhibit a response an automatic response in order to provide another non-automatic response? And what they will ask people to do is name the color of ink the word is written in, while ignoring the word that's written. And if you just try this on your own, it's pretty difficult. I usually show my Psych 101 students this test when we talk about cognitive psychology, because it's kind of fun to look through, but it's frustrating when this happens in the real world and you can't inhibit one response to get to somewhere else. Another test that I don't have pictured here, but is often used is a test of verbal fluency. So this would be verbal memory, word retrieval. Those are often reported as problem areas. So this is called the Controlled Oral Word Association Test. And how it works is that you're given 3 minutes to think of all the words that you can that start with the letter F, and then 3 minutes to think of all the words you can that start with the letter A, and then the letter S. And it's a measure of fluency, so being able to sort of expand on, given a limited amount of targets, or, given this limited information, like it has to be corresponding to this letter, how many things can you come up with? And then you can look at the number that people score on that. For animal research, this is an example of a test called the Morris Water Maze, which is used to measure spatial memory. And what they will do is they will put a mouse in water, and it's opaque water, so they can't see through the water. And there, you can't really see them in this picture, but there's picture cues outside of their environment that they can use to somewhat orient themselves in space. And what they will do is place them in the water in the same spot every day. And somewhere in this water, there's a hidden platform. They can't see the platform because the water is opaque, but they can, when they get to it, they stand on it. And mice can swim, but they really don't enjoy swimming, so they're motivated to find this platform. And we can use this as a measure of spatial memory. So how many times does it take for, how long, again, reaction time is what's used here. How long does it take for the mouse to find the hidden platform? And you can see usually on the first trial, they're kind of swimming around the area and then they find it, but after a few trials, they learn it pretty quickly. But if you give them chemotherapy or hormone therapy, this might impact their ability to solve that problem. And then finally, neuroimaging studies might give you data that shows how energy is being utilized in the brain and in what areas. So they might use things like glucose metabolism with a PET scan, and they might use, it's tomography, not technology. So they have the same verbal fluency problem, and the words come back eventually. So positron emission tomography. But this is actually looking at fMRI data. So it's telling us where the oxygen is, where the brain is utilizing the most oxygen. And that gives us an indication of what brain areas are working to solve problems. The next thing that we can talk about is what are producing these changes. So chemotherapy is an obvious one, and that's the term chemobrain, where that term chemobrain comes from. Hormonal medication should be another somewhat obvious one, just because we know how broadly estrogen receptors are within the brain. So because tamoxifen and aerobidase inhibitors are blocking estrogen, they should be able to impact the brain areas that are also rich in these receptors. I'll talk more about these in a few minutes, but these are sort of the two obvious ones. The less obvious ones could be inflammatory processes or things that are called paraneoplastic changes. And these could be changes that are produced by the cancer itself or our physiological response to a tumor. So this might be changes in vascularization. This might be changes in inflammatory substances like cytokines that are within the brain. And so this part could explain why some people may experience some of these cognitive changes prior to chemotherapy. I also included in here trauma-induced changes. And, I think I have to be careful in using trauma-induced changes. But again, because I'm also able to speak from, personal experiences as well as just what the literature says, a cancer diagnosis can be pretty traumatic, I think, to anyone at any time of their life. But if it's coming as a surprise and it suddenly disrupts your life and it needs to be dealt with, at the expense of other things, I don't think it's too far off the mark to look at some of the parallels or some of the things that are common between trauma and its impact on cognition and then a cancer diagnosis. So, sometimes things that could result from both trauma and a cancer diagnosis could be depression and anxiety. So maybe, depression and anxiety are things that we could look at to examine, either the consequences of cognitive changes or, how they could contribute to cognitive changes as well. There's other influencing factors like sleep. And again, I put anxiety and depression on here again, but that's, it's really hard to determine what's a cause or what's a consequence. I think doctors are quick to say that this is a cause of cognitive problems, but really these are all correlational studies, which means you can't determine causation. You can, it could equally be a consequence. What happens when you start to experience these cognitive changes? Well, they could produce anxiety because you may not be able to work as efficiently as you were before, and maybe you could lose your job. In addition, it can be depressing after a while if you start to, embody some of this, like, I'm not how I used to use, like, what is this cancer taken away from me? So I don't think it's too far off the mark to say that these could also be consequences, not necessarily causes, to some of the changes. This is a big slide. I'm not going to talk about each of these, at length, but this is an image I took from a paper that looked at some of the things that could contribute to the cognitive functions. And it includes some of the risk factors that might occur. So for instance, because there's that wide variability in who's affected and for how long, that means that there's probably individual factors that increase or decrease the risk of cognitive impairments for you. Some of that may be due to genetics. Some of that may be due to the cancer and the treatments that you get. Some of that may be due to things like post-traumatic stress, motivation, fatigue, anxiety, depression. And some of that could be due to education level, cognitive reserve, and age. For example, some of the things that I was reading was that the younger you are at diagnosis, the more pronounced some of these cognitive effects can be. You have to take into consideration if someone has other comorbidities and what we can do to manage these symptoms. Okay, so I want to go through some examples, and I want to be conscious of time. And so what I want to do is go through one example with memory using animal and human research. So the first place that I'm going to start is with memory processes. And I am showing you here a picture of a brain structure called the hippocampus. It sits in the midbrain, and the area that we're really interested in is something called the dentate gyrus, which is right here. We know that this area plays a role in consolidating new memories, and it's one of the only sites in the brain that that new cells are born. So when we think about stem cells and we think about the central nervous system's ability to regenerate, we generally think that there isn't much that the CNS can do. But in this area of the hippocampus, we know new neurons are being born, and we call that cell proliferation. This is mouse samples of this area, the dentate gyrus in the hippocampus. And what we are looking at here are the effects of chemotherapy on cell proliferation in this area. So cell proliferation is new neurons being born. And what we can see, so this is what it looks like in a mouse that's injected with saline. This is with different chemotherapy agents. And what you can see is that there's an absence of this cell proliferation throughout all of these chemotherapy drugs. What's interesting, though, is only one of these is known to, cytoxin, which is this one, is known to cross the blood-brain barrier. The blood-brain barrier is what it sounds like. It's a barrier that protects the brain from harmful agents getting in. It's not a perfect barrier, and a lot of things can be passed through or actively transported through. But one of the problems in research, especially with brain tumors, is that the blood-brain barrier doesn't allow some chemotherapy molecules to enter because those molecules are too big. So things like arimidex and tamoxifen, they readily cross the blood-brain barrier. But things like Taxol and adriamycin are thought not to. So what's really interesting about this study is that the effects of these drugs on cell proliferation are present, even though these drugs weren't known to cross the blood-brain barrier. So this is important because doctors may have been more likely to diminish the effects of chemobrain, or say that, that can't be true because these drugs don't cross the blood-brain barrier. Well, here is evidence that yes, indeed, it can be true. And these drugs are doing something. We may not know exactly what yet, but they're doing something that prevents new cell growth in the brain area that's important for consolidating new memories. And what this also tells us is it's not that the damage is coming from killing off cells that are there, but preventing new ones from being born or continuing to grow once they're born. So to bring this up to the level of human research, I wanted to go over some research with verbal declarative memory. And this is the ability to kind of like, we sort of, I don't know if you're like me, but you might talk to yourself a lot and say, like, you put your car keys down somewhere and then later you can't find them. And you're like, I know I put them right here. Where are they? And then you start to say, well, maybe I did this, maybe I did that. That's sort of the functional equivalent to a verbal declarative memory task. And in this study, they looked at women who had locally advanced or metastatic breast cancer, and they compared them to match controls who had the same level of education and no cancer history. They scanned them during two parts of a task. During encoding, where they were given a word like tree, and they had to choose whether that was man-made or not. So they'd push a button for, yes, that's man-made, no, that's not man-made. And then recall. So on the recall portion of the test, they might give them a similar word like plant, and then they had to recall if that was a word they had seen previously. And what you can see is happening here is, first, in terms of performance on the neuropsych portion of this test, there's no difference in accuracy. Both the people who experienced chemotherapy and those that didn't are similarly accurate in their response. What's different in this case is that there's less activation of the prefrontal cortex areas during the encoding. So this is the person who has no history of cancer and or chemotherapy, and they're recruiting the frontal regions of their brain. Their nose would be here, this would be the back of their head. And when you look at that same area, if this is a composite of the 14 people, you see that what's really missing is the frontal cortical regions being activated to do this task. They're also, so the person who's had, or the composite of the people who had chemotherapy are showing activation in all of these other brain areas that aren't showing activation here. But the part that's really critical to the task is not being activated. In addition, during the recall, the people who experienced chemotherapy showed more activation of parts that should have been at rest. So the parts that were resting in the people who hadn't been treated were active in the people who had chemotherapy when they had to recall if they had seen that word before. So what's interesting about this is that we can't really see this difference when we're looking at just test performance, right? So when we're going off of just neuropsych performance, this difference doesn't necessarily emerge because this difference is due to the way that we got to an answer. So it's showing, the neuropsych test is showing us the outcome of the cognitive process, but the difference really lies in the cognitive process, how we're going about solving that problem. Here's another example, still using memory, but this is a different type of memory now, using working memory. So working memory is, like I said, when you might go into a grocery store and you have to remember a list of items, or someone gives you a phone number, and before we had, cell phones, and we could just say, why don't you type in your number and call, or text me and then I'll have it, when we would have to kind of re-loop those numbers until we could consolidate them into a long-term memory. So what we're looking at here is two twins. So we have one who had breast cancer and chemotherapy and one who did not. They're monozygotic twins. That means that it was one cell that split into two. So they should have the same genetic material, and they should have a very similar rearing environment. So, they both lived in the same house. Yes, they could have slightly different experiences just based on being an individual, but in terms of education level, demographics, where they grew up, their genetics, a lot of things are held constant. So it makes an interesting case to look at. And what they were given is a neuropsych test called the NBAC. N just means number, and it's a working memory task that requires a person to listen to a string of consonants, and then you have to say whether the letter you just heard was a D or the letter was a letter that you heard just before the D. And so just before the D would be one back. Two back would be, is this a D or the letter that you heard two letters before the D? And three back, is this the D or is this the letter that you heard three letters before the D? So you can see that this test gets increasingly complex as time goes on. And what we're looking at here is the sister with chemotherapy and the one without performing that test. Again, there's a lot more activation of different brain areas and energy expended, even on the easy task for the twin who had chemotherapy. This is 22 months post chemotherapy, by the way, when they were scanned. And she had been on tamoxifen, I think, for 18 months at this point. But what you can see pretty clearly in this is that the twin who has been treated is using more widespread networks in the brain and working harder on the task. What's interesting here is that they got the same score on this test. So again, if you're only going off of the performance on neuropsych tests, what you're missing is that there's a difference in how people's brains are working. So there's no difference between the twins on accuracy, but the treated twin recruited more brain areas and had to use more energy to achieve the same level of performance with her as her twin. Again, there's no difference or presence of anxiety or depression in either of the twins here. So we can be pretty confident that this is a cognitive effect of treatment and cancer versus something else. So what does this tell us? It tells us that when we use scores on neuropsych tests alone, the self-reported concerns may appear unjustified. So if our doctors are reading the studies on neuropsych tests, they might be like, oh yeah, there might be a slight difference here, but nothing that's significant enough to impact your life. But when you look at the brain imaging studies, they're telling us a different story. They're telling us that you're working harder and you're recruiting more brain areas to achieve the same level of performance that you had before. So this is kind of what I thought that it means about the results. Like, what are the results of this? Is that, you know, this explains a lot why I'm tired all the time. And you might joke about like your secret talent is getting tired without doing anything, but you know, you're really doing a lot more than you may have had to do before. I think it also goes along with that first slide I showed you, right? We expect that we're going to just progress at this level and it's going to be linear. But, you know, these two individuals are getting to the same point eventually, but this person is having to work a lot harder to get there. And then finally, this is just memes that I saw, but, you know, trust me, it's more frustrating than it is for me than it is for you. It's because this is hidden from view. You know, this process, people aren't necessarily watching or privy to what is going on. And it could diminish, you know, the believability, the reality of some of these things. So I thought that brain imaging research would sort of be an interesting direction to take this. Now, the next thing that I have to cover is hormone therapy. And you can please stop me at any time if I'm starting to run into the question time. I don't really have a lot more besides the hormone therapy in this presentation. So, but feel free to stop me if I'm using up too much of the time. We know that 75% of breast cancer patients can get some benefit from hormone therapy. It's generally aromatase inhibitors or what we call SERMs, which are selective estrogen receptor modulators. These are generally given for long periods of time, anywhere from 5 years to 10 years to 7 years. You know, the research is still on. What they're doing at a functional level, the aromatase inhibitors are inhibiting the function of two estrogen receptors that we know about, the alpha and the beta estrogen receptor. And the SERMs have a slight stimulatory effect on the alpha receptor, but inhibit in total the beta receptor. So if we look at the brain areas that are rich in these receptors, the alpha receptors are rich on the hypothalamus, which regulates hormones. That makes sense. They're hormone medications. And the amygdala. The amygdala is important in our appraisal of threat. And the ER beta is in the thalamus and the hippocampus. Again, these is again within the temporal lobe. So it makes sense that these could have an impact on our memory. The hippocampus is that structure that we talked about before. We know with animal research, if you take out an animal's ovaries, they have decreased performance on spatial memory and working memory. So something like the Morris water maze where the mouse has to swim and find the target, that would be impaired. We can look at human research without, adding or taking away drugs. We know that there's menstrual cycle changes in cognition for women who are naturally cycling, so not taking hormonal birth control or anything. Estrogen enhances verbal fluency, and we see that spike right at ovulation. And then we can look at clinical research. There's two studies that I have here to talk about. The first one is the aromatase inhibitor and tamoxifen, and aromatase inhibitor and tamoxifen combined trial. And they looked at differences, and they found differences in verbal memory processing speed, but there really wasn't a distinction between, the aromatase inhibitors producing a more consequential result than tamoxifen. And then the team study, which is tamoxifen, exemestane, adjuvant multinational study, is the tamoxifen group showed more trouble with executive functioning and verbal memory compared to the controls, and more processing speed difficulties compared to the aromatase inhibitor group. The aromatase inhibitor group showed no impairment. But again, if they're using neuropsych tests as their dependent variable or the measured variable, it might be excluding some of the changes that are taking place. And then the last piece, I wanted to be cautious in interpreting changes that could occur via trauma, but I've done some work in trauma and the way that in particular, the way that it impacts the brain. And we know that trauma can induce changes in threat perception. That's a midbrain area called the amygdala that we know is also sensitive to hormone receptors. And it also induces changes in filtering. And filtering is more of a cortical process, but it helps us determine what's relevant versus what's irrelevant in our environment, right? And that's trouble. Like if you are not able to filter out the stuff that isn't needed to solve the problem you're working on right now, you're not going to be efficient at solving that problem. And another piece that trauma can induce changes in is the sense of self, and not like a whole body, but in the areas of the brain that we know are related to processing self-reference material. So that some of the structures in the more on the right frontal lobe than the left frontal lobe. And some of this is due to coping. So, trauma usually is felt within the body. We get like gut-wrenching or heartbreaking emotions. And, part of our body's, this is one theory, part of our body's defense to that is just sort of like blocking or not feeling that as much. So I think there is a place, cautiously in the breast cancer research where we could look and see where these co-occur. Because if you look at the effects of mild traumatic brain injury and PTSD, they both, I know this slide, I could not find a slide where this wasn't as blurry. But anyway, they both impact cognitive dysfunction, sleep disturbance, mental processing, depression, anxiety, fatigue, other problems that might be, present within the body. And so there's a lot of overlap. And I think that's something that could be explored further. So to sort of finish, I know that the cognitive sequelae following cancer treatments can be frustrating. It can also lead to either a comorbidity or having a secondary effect of things like anxiety and depression. And this can sort of become a loop. Like if we get hard on ourselves or, I made that mistake and like I disappointed people at work, then we start to internalize that. We might get anxiety about doing that again. We may also get feel some guilt or some shame about that. And it's a cycle. It goes back and impacts that. So be kind to yourself. And when it comes to treatment, I know a lot of what I'm going to say are things that you probably are no stranger to. So I'm not going to go through things that you've already probably heard about, but we know there really aren't any FDA approved treatments available to help specifically with cancer-related cognitive impairment. There are some medications that could be helpful. Some things like cognitive remediation, where they're teaching different strategies to sort of help cope with and get better at things that are more difficult now. Things like exercise have been useful, all the things like sleep, diet, and nutrition that we know about already. And that should be social support, not special support. So I know that we kind of know these things, right? Sleep, diet, nutrition, yes. It's not so much we don't know how to do them, it's actually getting to do them. So one thing I thought I could share that might help with coping is a strategy on setting goals, so that if you do have a particular sleep goal or nutrition goal or diet goal, you can use it. And it's just how you create it. You make a goal that's specific. So that might be, you know, exercising 30 minutes a day, twice a week to start. It's measurable. Okay, 30 minutes and twice a week, that's measurable. It's attainable. I'm not saying I'm gonna suddenly, you know, exercise 2 hours. It's relevant, it's going to get you to your goal, and it's time-based. You can measure that. You can say, for, you know, I'll assess how I did on this in 2 weeks. So those are things I'm happy to talk more about in the question and answer section. Again, any questions that you might have, I'm happy to field. And in here, I included my contact information and my email. You can feel free to get in touch with me whenever you want. And yeah, that's a picture of me at my first infusion of chemotherapy. So thank you very much for your time, and I'm happy to take any questions.
Hi, Dr. Bremser, it's Eileen. Can you hear me now?
Yep, I can.
Oh, good. All right, so we do have a couple of questions, and I would like to get right to it if we could. And so one of the questions that came in early in the presentation was on supplements that affect mental functioning. And this the question came in on the supplement Prevagen, but it probably could be a broader question of, can those supplements potentially help people deal with some of their cognitive issues related to breast cancer treatment?
So I think that the research on, like, large scale research using a clinical trial type design, there hasn't been anything that's been approved for it in terms of supplements. Now, there may be some studies showing a small benefit of people in certain settings, but nothing that would meet sort of the gold standard of an FDA approval. But with that said, you could always talk to, you know, a doctor. Like, I'm not qualified to give medical advice in terms of supplements or anything, so I want to be cautious in my answer to it, but I also want to address your question. So you know, you could look at certain things, and maybe even if you know that they're safe to take based on your oncologist or your PCP approval, you could try out and see what might work. So I know there are some larger scale studies looking at DHA, and that's like omega-3 fatty acids. And those are used to help build, those are things that we only get through diet. So if you did have a nutritional deficiency and that was partly to cause some of the problems that you're having, then replenishing that through diet would definitely help. I mean, it should, in theory, it should definitely help. So that might be one area to look at. And what I can tell you about those like omega-3 fatty acids is that the ones that you're looking for are long chain polyunsaturated fatty acids, and that's like omega-3 fatty acids. Those are utilized by the brain to support like both like for babies, for the development of the nervous system, but also keeping synaptic connections sharp or connected, I guess. And I've done research with those just based on where body fat is distributed. And we know that the fat that composes like your belly and your hips and thighs is made up of a different composition. So the belly that's sort of on your hips and thighs is rich in those omega-3 fatty acids. The ones on the belly are more rich in omega-6, and those are problematic to brain functioning. And the long chain polyunsaturated fatty acids are associated with cognitive ability. And I could point you to more research on that if you wanted, but that might be worth exploring, and you can get that through diet, through fish, through plant supplements, things like that.
Okay, that's a good answer. Thank you very much. All right, so I do have another question here. What rehabilitative approaches are available for cancer patients that are noticing cognitive changes. This particular writer, I've previously had significant TBI and was in a rehab program that worked with cognitive functioning for a year. And the secondary part of that is how can a person access these kinds of programs?
Yeah, that's a great question. So I would go either through your oncologist or your PCP and get a referral to a neuropsychologist. So a licensed neuropsychologist is going to be a person who can give you these neuropsychological tests to assess your performance, but they also can do cognitive rehab programs. In the Capital District, I know that there is a practice called, so I remember it by CNS because like central nervous system. I think it's called comprehensive. So I'll type it down here in CNS. I think it's comprehensive neuropsych services, and it's by St. Rose. Is that Western Avenue? I used to live in Albany, but I don't. I think on Western Avenue. And the person that runs that clinic has also does cognitive rehab there. So she does the neuropsych testing, but then she can train technicians to administer the cognitive rehab portion of it. There's probably other places. I've heard of speech language pathologists and occupational therapists doing that as well. And so you might want to look, for a referral or call around occupational therapy offices. You might be more likely to get it covered by insurance through an occupational therapist than through a neuropsych. Sometimes those services aren't, but I would say those are places to start. And if they say, you're not really meeting criteria for a deficit, it's just be like, you don't have a baseline on me, so you don't know what I was like before, because you probably haven't had that. And then you just be like, this is looking at the end point of my cognitive process, but not the process itself. So, you're happy to use any of the research in here, but you may have to advocate for yourself a little bit to get that and get either the oncologist or PCP to agree for the referral. But the squeaky wheel gets the grease, and that's how I would go about it.
Good deal. Thank you. All right. Some of the tests mentioned are used to diagnose dementia. Would you say that if you have a CRCI that you can be predisposed to a dementia diagnosis?
Okay, I was hoping for this question because I think that the research is not really clear on this. So this is what I will say for that. So the process of Alzheimer's or dementia, like the physiological mechanisms of that, are different than what you see in cognitive-related cognitive impairments. So it's a different process that's occurring. So if you are working with somebody that has a cancer-related cognitive impairment, if you give them a list of words to remember, and the word might be blue, and you do that with someone who has dementia or Alzheimer's, in 5 minutes after you distract them with other tasks, neither of them may be able to remember the word that you gave them. But if you tell a person with cognitive-related cognitive impairment or cancer-related cognitive impairment, if you say it's a color, then they might say, oh, that was blue. So that cueing tends to help a person with cancer-related cognitive impairments, but that cueing really doesn't help somebody with Alzheimer's. So there's a difference in how that works. And so the cueing is a good thing. It's something that you can use for your advantage. Now, are you more at risk of dementia because of this impairment? I would say that this is where genetic research comes into play, because people who are more prone to the cognitive effects of chemotherapy are also more prone to dementia, but that's because of a genetic variant. They're also more prone to the cognitive consequences of a traumatic brain injury. So it's not the chemotherapy itself that would increase your risk for this, but it may be because of an underlying genetic predisposition for this. And the one that's been most researched is in my presentation. I'm not going to be able to remember it without looking back, but I can go to it quickly here. It's APOE. I'll put that in there. So and it has to do with a protein. It's called like I'm not going to be able to pronounce it the way a medical doctor would pronounce it, but it's something, a lipoprotein or something like that. So you could ask if there's any sort of screening that could be done. You know, if there's any hereditary history of Alzheimer's or something in your family, then it might be, you know, worth even engaging in some of the cognitive remediation before things start to slip, because, you know, the goal would be to get to the working on these things as a preventative versus a remediation. So, you know, that's what I think people are trying to do now with research.
So Dr. Bremser, I'm going to ask one more question, I think, and just being cognizant of people's time and your time. I know we've gone past an hour, but you gave us so much information today that I think people really had a lot to absorb, and I think it addressed a lot of the questions up front. So a related question to this research piece. Are there studies that compare those receiving cancer treatment and cognitive functioning rehab to those who have not received such services during their treatment?
I think this research is ongoing. One of the things that people are working on, I know University of Rochester, seen some of the authors I was coming across. There's a woman whose last name is Ferguson. That might be a man. And then there's two names that came up often. It was like Janelsons and Ferguson. And I noticed that one of them had received a grant to, one, identify more sensitive neuropsychological tests that can capture some of the changes that I talked about, and then to compare them. So at this point, I don't know of one, but that's what's needed to really find an FDA approved treatment. And so FDA approved treatments don't have to be medically based. It could be based on the cognitive rehabilitation strategies, but I'm not aware of those now that have gotten enough evidence behind them to give them FDA approval.
Okay. You know what, there's one more question here. I think this is a good one that I'd like to get in. Do you have time?
Yeah.
Okay. All right. How likely is the CRCI to improve once hormonal treatment is finished? This person had 2 years ALS and now going aromatase inhibitor, now going on tamoxifen for a year. I do not have chemo. I have not had chemo. Had the neuropsych test and was told not enough deficit to receive further evaluation or therapy.
That's frustrating, one, but again, I think that research is still ongoing on how quickly it resolves, but I can talk to at least personal experience of that. So I did 5 years of tamoxifen and I finished it in May. And within a month of being off of tamoxifen, I noticed a significant change. So, you know, I'm anecdotal. I don't have a big end to back up what I'm saying, but it was very surprising to be off of the medications and then I you know, people say like a fog clears. It kind of did. It wasn't, I didn't really realize I was living in a fog, but I would have a lot of trouble with that working memory piece of being able to hold something in my brain long enough to do it. And I have to do that all the time in my job when I'm like making, you know, lectures or presentations and stuff. I have to take what I'm reading and then put it into words and then teach from it. And that got better. Like I was like, I can remember a phone number without this. And even as I was writing this presentation, I'm like, can I get those numbers right and still remember? So I felt like part of me and how I worked before was back. And that happened pretty rapidly after that. Now I was premenopausal going in, premenopausal going out of the hormone therapy. What I think is a problem in this area of research is that the timing of breast cancer and menopause can kind of go together. So, you know, it gives doctors an easy out to be like, yeah, well, it's menopause. And it's like, it might not be. And so I think that we need to look at it, you know, taking into consideration menopausal status and how long someone's been off of the treatment. But I wish I had a neuropsych test right before I was done and again after to see.
Good, thank you. So I'm going to wrap up questions and I'm going to say thank you for all that you were able to impart in terms of knowledge. I think everyone feels that they have gleaned so much more just general perspective on, our unique and wonderful brains, and how we can process things. And so at this point, I'd like to introduce Melanie Mccully, our Support Services Program Manager, and she's got a couple things to say as well. Melanie?
Good morning, everyone. Thank you so much for attending the program. Happy New Year. It's hard to believe it's 2021, but here we are. Thank you so much, Dr. Bremser. That was amazing. We had such a great talk last week. I knew it would be. I'm so glad so many people could join us this morning, and I know how valuable your material is to our community. So this was the 5th of our 6-part Women's Health Conference. So we only have one session left. That will be January 26th. With Dr. Khan from St. Peter's Health Partners. So if you are still interested in that program, that will be on complex and metastatic breast cancer diagnoses. And there is still time to register if you're interested. So again, get registered for that if you would like to participate. As always, in a little bit, you're going to be receiving an evaluation, and we really appreciate if you could please fill that out. It takes only a few minutes, but the information is invaluable to us. And just letting you know, Two Life is still functioning as we have continued to be. Our support services programs and all are still remote, so by phone, by email, by Zoom. I'm more than happy to meet with anyone in any of those formats. And we are open in terms of our boutique services. So our wig, hat, and scarf boutique, and also our mastectomy boutiques are open by appointment only and with very strict screening and protocol. So please feel free, if we can be of any help at all, please contact us. And again, thank you, Dr. Bremser. Thank you everyone for attending, and we look forward to seeing you on January 26th. Take care.
Thank you very much.